A good morning to everyone, to my dear students. How are you? Let me hope your life is good. Yes, today I want to talk about a term called intrauterine growth retardation, which all of us have ever heard about, or it is abbreviated as IUGR. For some of you who have gone to the hospitals, you have seen these abbreviations in the patient's file. So we want to understand why IUGR, and maybe the causes, and maybe the management and the repercussions of intrauterine growth retardation. So by definition, we define intrauterine growth retardation. It is also sometimes called intrauterine fetal growth restriction, which is a term which refers to a condition where a fetus does not grow to its expected size and weight during pregnancy, typically falling below the 10th percentile of the gestation's age. Yes, when a mother gets pregnant, we expect that the baby is gaining weight each and every month. And this accounts even to the abdominal size. When you look at the mother, the abdominal size continues to grow. Again, it also accounts for the weight of a mother during pregnancy. That is why in most cases, when the mother comes for antenatal, we take her weight and we expect the weight to continue to grow. But when the baby is not growing, even the mother can detect it when she looks at her abdomen and the abdomen is like it is not increasing. The mother can report that. So when the baby is not growing to the expected size and the expected weight during pregnancy, but when the fetal heart is viable, we call that term intrauterine growth restriction. What may be the causes of this? We may have both maternal and fetal factors. When we look at maternal factors, we can say hypertension. And when we talk of hypertension, both chronic and pregnancy-induced hypertension or preeclampsia reduce the placental perfusion, leading to poor fetal growth. How this comes about? Remember, during hypertension, there is what we call vasorestriction or constriction, that the blood is pumped to various parts of the body, but the veins and the arteries are constricted. So this can also affect the placental perfusion, that the blood which is pumped through the placenta to go and serve or feed the baby is also restricted. So this can bring about intrauterine growth retardation. When we talk of maternal nutrition, when the mother herself is malnourished or does not have enough food, anything that brings about maternal malnutrition, it can be sickness, etc. This is well explained that if a mother herself is malnourished, it means even those food values which are supposed to pass through the placenta to serve the fetus are going to be minimized. Therefore, even the fetus will look malnourished. Thus, intrauterine growth retardation. Anemia is a common case in pregnancies, whereby mothers get iron deficiency anemia, vitamin B12 anemia, and folate anemias. All these anemias, they reduce the oxygen supply to the fetus, because somewhere we know that the heme is the one which attracts oxygen. And then when the mother have reduced hemoglobin, then it means that the fetus will also get reduced hemoglobin. And remember, the fetus intrauterine, because it has some patent structures in it, it needs a lot of oxygen. Therefore, if a mother herself is anemic, therefore the fetus itself will also become anemic, and therefore it will have intrauterine growth restrictions. Then when we talk of maternal infections like rubella, cytomegalovirus, or toxoplasmosis, all these, even malaria, all these infections, some of these, they pass through the placental barrier. And when they pass through the placental barrier, they are going to go and impair fetal growth. It means even the fetus can get infected. And when you look at even infections which may not pass through the placenta, these infections themselves, they cause a problem to the mother. Because when a mother has an infection, this mother will vomit, this mother will not eat, this mother will have a lot of problems, of which all the metabolic disorders or problems will be transferred to the fetus, and hence the fetus may not grow to its expected size. Now, when we look at mothers who abuse substance, like mothers who smoke, mothers who take drugs like cocaine, marijuana, etc., just know that all these substances lead to vasoconstriction. Therefore, the fetus itself will be affected. As earlier said, that any problem which is affecting the mother, any condition, here we talk about things like renal diseases, diabetes mellitus, autoimmune disorders, all these conditions lead to intrauterine fetal retardation. Then we have the fetal factors. When you look at fetal factors, we may mention many, but a few here. Chromosomal abnormalities like trisomy 13, 18, and 21. When we say trisomy, it means that instead of this gene coming 1, we inherited 2. Remember, we have to inherit 1 gene from the maternal side and 1 gene from the paternal side to make a total of 26 chromosomes per normal individual. 23 from the mother, 23 from the father. But at one time, instead of getting 1, like at gene 13, gene 18, and gene 21, instead of getting 1 from one of the parents, we may inherit 2, and that is why it is called trisomy. Because when we inherit 2, then we get 1 from one parent, then they end up being 3 instead of being 2. So this is an abnormal gene multiplication, which brings about congenital conditions like Mongolism and mental retardations. All this, and also they cause a lot of congenital abnormalities, which brings about intrauterine growth restrictions or growth retardations. Then congenital abnormalities like structural abnormalities, which may hinder the normal fetal growth. Structural abnormalities, this may contain the main organs we have in the body, like the kidney, the heart, the brain, the liver, etc. When these organs have malformations, of course they affect the growth of the fetus intrauterine. Then we have multiple pregnancies. These days it is uncommon. We have the twins, the triplets, the quadruplets, etc. Mothers are delivering multiple babies, others by IVF. These days it is very common. And with IVF, intravitreal fertilization, the mother gets more than 1. And that who survives is what the mother will deliver. So when you look at multiple pregnancies, of course the demand is high from the mother. The demand is high, the space is small for the uterus, so these babies may not grow as a baby who is intrauterine alone. So this one also brings about intrauterine growth restrictions. Then we can also talk of the placental factors, whereby we talk of placental insufficiency, whereby the placenta cannot function like expected. For example, when there are some sicknesses on it, for example, the commonest is the syphilis, which affects the placenta. Again, the placenta won't be able to function as expected. Therefore, it can lead to intrauterine growth restriction. Some placental abnormalities can also lead to placental insufficiency. So then we have placenta abruption. Placenta abruption is the premature separation of the placenta that can limit the blood flow to the fetus. All of us know that the placenta wholly attaches on the fundus or above in the upper segment of the uterus, and this area it attaches is a very good for placental diffusion. That is getting nutrients from the maternal side, then to the fetal side, and then vis-a-vis for excretion. But when this placenta separates, due to very many causes, it can be sickness, it can be an accident, anything can cause a premature separation of the placenta. It can be seen, or sometimes it can remain hidden, and this mother will notice that her baby is not growing well. Then we have placenta previa. Placenta previa is implantation of the placenta in the lower segment of the uterus. All of us, you remember the structure of the uterus, that in the lower segment we have the longitudinal muscles in the isthmus, and sometimes this placenta goes further to implant even over the cervical os. So this brings about poor perfusion, that the placenta cannot work very normally to perfuse the nutrients from the maternal to the fetal side. Then we talk of environmental factors. These may be predisposing factors like high altitude, and we say that low oxygen levels at high altitudes can affect fetal oxygenation. Like, for example, when we talk of altitude, that is geographical. That is geographical, and it can even be those people who work in like air hostesses and all that. So it can lead to low levels of oxygen the higher they go, and because they are low levels of oxygen, it can lead to low oxygen perfusion to the fetus. Then toxins and radiations also cause intrauterine growth retardation. That is, prolonged exposure to environmental toxins and radiations can lead to that. People said that in the World War there was a lot of toxins which came about by the bullets, those things they used to use for fighting. But for this era we can talk of what we know. Let me say people living near factories, for example, tobacco factories, for example, mothers who work in coffee factories, those mothers, those pregnant women who may work in what? These areas where they grow flowers. There is a lot of drugs they spray to those flowers. So these can all lead to toxins, and these toxins in a long run they can lead to intrauterine growth retardation. Okay, we can continue of other predisposing factors like maternal age greater than 35, history of intrauterine growth retardation in previous pregnancies, poor socioeconomic status, maternal smoking, alcohol and drug abuse, all these things we have talked about them above, presence of multiple gestations, maternal infections, etc. So when we talk about that, we can try to think about intrauterine growth restriction.